the different aspects, going from what we think of modern medical ethics and tying it back in through the Hippocratic Oath and the other documents and codes of conduct and that John's already mentioned. So I guess certainly what the modern thoughts on medical ethics, particularly in the Western world, is around the 4 principles of respect for patient autonomy, beneficence, so doing well for your patients, doing the right thing by them, helping them, non-maleficence, or doing no harm, first do no harm, which we'd all be familiar with, and then the idea of justice, which takes on various meanings, treating people equally, also around the distribution of goods and everything. So that's what we think of today, and that was really brought out by Beauchamp and Childress in, say, early 1980s, 1979. But how much does that tie into what maybe the Hippocratic Oath says? And given how much medical practice and knowledge has changed over those centuries, it's kind of interesting to look to see, well, does the ethics behind the way that you guys practice hasn't really changed that much? So, and some of this you'll be more familiar with the Hippocratic Oath and that than probably I am. So I'm just going to touch on bits of it and see how we can tie it all together. And so within that oath, it talks about respecting the people that taught you, to be physicians and to pass on that knowledge. So maybe not medical ethics as such, but a really important thing in thinking about our patients' care, thinking about our own care and how we pass on knowledge from one generation to the next. But it also talks about treating your patients well. I think it says things like, devising the best diet according to what their needs are. So you can see in that the idea of beneficence. It talks about not harming a patient. Again, we've got that idea of maleficence, treating the patient well, looking after them, causing no harm. It gets into some very specifics. It talks about not providing poison to the patient, or with a pregnant woman, not basically bringing about an abortion. So it even touches on some of those topics that are still quite controversial in modern medical ethics. Another part of the Hippocratic Oath talks about when you go into a patient's home to treat them, to keep things confidential about what you learn in that home. Okay, so we've got that idea of respecting confidentiality, which we can tie back into beneficence, and also respecting patient autonomy. And also about relationships that you should or shouldn't be having with patients. So even back in, this is in maybe 4th century BC, it's understood that there's a huge power and difference between a patient and a doctor, and that you need to be able to acknowledge that and respect that, so not having any inappropriate relationships with your patients, and not using that power imbalance to your advantage. So this is the oath that's been taken for many, many years, and really the biggest next change that came around that John also touched on was the Declaration of Geneva. So if you think about that, came out first in 1948. So let's put it in context. It was at the end of World War II. We had the Nuremberg trials, the doctors' trials. So out of that came, well, 2 things. Within those trials, they talked about the Hippocratic Oath and said, well, this is, as a doctor, this is what you've sworn to, and the atrocities that you participated in obviously didn't gel with what you had sworn to. Okay, so that was used kind of in evidence within those trials. So out of the trials, we had 2 things happen. One, we got the Nuremberg Code. So that was the first really formal code of ethics for working with people within research. And you also, shortly after those trials, we had the World Medical Association coming out with the Declaration of Geneva. And again, based on the Hippocratic Oath, but really building on that and bringing it into context after World War II, what had happened, added several more keys, aspects of the ethical conduct of doctors. So it then brought in things around, well, even under threat, you should be treating your patients' health and life should be your first consideration. So even under threat of your own health or well-being, you should be putting your patients first. And you can see how that relates back to what happened during the war. But it also talks about treating people equally. So the idea of justice and not discriminating people based on their political affiliations or their race, their religion, or anything like that. So those were a couple of the main things that was added in this first example of the Declaration of Geneva. And that's gone through various updates as medical technology and abilities and everything changes, so it updates it. One of the really important things, and that's been touched on, that was added in one of the later editions, is this idea that doctors have a responsibility to look after their own health. So we can again tie this back to those 4 overriding principles that we think about of beneficence and non-maleficence, is that if you're not in good health yourself, now whether that's physical, mental, or whatever, you're not going to be able to do the best thing by your patients. Okay, so you may be bringing about harm to those. So the Declaration of Geneva specifically says, doctors, you need to be self-aware. If you think you're not well, you need to be able to reach out and get help. You need to be able to stop and so maybe go, well, I shouldn't be treating my patients because I'm not going to do the best thing for them. And also, I guess your colleagues should be able to recognise this and provide some help, or, you know, if needs be, report it to the most appropriate authority or people to get help, because they can see that it's not only an issue for the doctor, the person themselves, but it's also touches on for their patients. Some of those updates have also included things. I guess it has increased the look of how to treat people fairly, so taking into account not discriminating against their gender or their sexuality and everything. So that's kind of just moving with, I guess, more modern times. There's been a bit of a move away. I guess, you know, I mentioned the Hippocratic Oath, touched on the big ones of abortion and euthanasia. I guess there's a recognition that with the changing thoughts on, you know, the sanctity of human life, when human life begins and things like that, the Declaration of Geneva has kind of stepped back and said, you know, the health of your patient is your primary concern, whereas it used to say their health and life. And I guess that's a bit of a nod to the idea, you know, the quality of life sometime may be the major concern rather than necessarily the quantity of life. And just like in the research ethics where we had the Nuremberg Code and then we had the Declaration of Helsinki, and then Australia puts out its own statement on the ethical conduct of research in people. We also have the medical associations within Australia have added to the Hippocratic Oath, added to the Declaration of Geneva and built on those, and added some more guidelines for the Australian doctors in the Australian setting. And I guess some of those are helpful for taking into consideration also the ethics of, for a doctor, recognising your own beliefs, maybe your own religious background, your own cultural backgrounds, and saying, you know, it's okay for you, if you don't agree with a particular procedure or something, you don't have to participate in it, but you do need to let your patients know that you know that this isn't something that you support or you're willing to do, and have be able to refer them on to someone else. So for people within your organisation that work in more remote areas, this is probably something that you really need to think about, because you have to be thinking about the, you know, what's for the good of the patient. Is there going to be someone else that they can pass them on to easily? You know, is that going to mean that that person then has to travel 5 hours to see someone else? How do you deal with things like that? And also specifically the Australian medical, the code talks about that doctors shouldn't be treating their own family or their close friends and colleagues. So if you go behind the thinking behind that, and let's relate it back to those medical ethics, you know, if you're treating someone that's close to you, are they going to feel free to provide all the information that they might provide to someone that they don't have that close personal relationship? Therefore, are you actually going to be able to treat them in the best possible way if they're actually holding back some of that information? Are you going to ask the same questions to them that you would ask someone else in that situation. So again, in a similar way, if you need to be taking those things into consideration if where you're working is quite distant from and there's limited other alternatives for doctors, for them to see how are you going to deal with that, and kind of, I guess, you need to think about these things in advance. Obviously, in both of these situations, when there's emergencies come up, that's a different category. And, you go back to beneficence, you've got to do all you can do to treat that patient properly and that, but also understanding that under normal circumstances, if it's not an emergency, how are you going to uphold these medical ethics, but still allow the patient to be treated well? I think those are the main points that I wanted to touch on. And I guess what it really says to me, that although we have had huge advances in medicine, and that the medical ethics that actually underlie how we treat patients probably is very similar. It hasn't changed all that much. If you think about with the pandemic, how are we treating people with the vaccine that's now available? How do we prioritise who we're going to give that to? We're still, I guess you have some utilitarian ethics coming in there. What's going to do the greatest amount of good? So you can see in the UK, they're going to give it to health professionals because, you need to be able to look after the people that are providing the care first, and then to the most vulnerable. So, so you still have those idea of beneficence, what's going to be of the greatest benefit to the most of the population, and the idea of justice, that you're actually, you're not going to discriminate against people in giving out this vaccine. Certainly in some countries, there is a worry that, is it just going to go to the highest bidder almost? And that I think we're probably in a lucky situation, one, that we haven't been affected so much, but also that, I don't think we really have those concerns. So that's all I was going to really cover, but I'm happy to take any questions or to expand on anything.
Thank you so much, Lynn. That was a great summary, a really comprehensive summary of the world of medical ethics. And you really hit on some of the key points that we've highlighted in the new Ochre Code of Conduct. In particular, we wanted to highlight the issue around not seeing people that are relatives of ours, or particularly staff that we work with that we know really well. Obviously it's not appropriate for us to see other staff, particularly about industrial issues. But as you've outlined, and a lot of us know, and we're taught in medical school, that we actually don't treat people as well that we know really well, that we really, really like, and people that we really, really don't like. There's evidence behind that we often cut corners. So it might be, you might be well-meaning. Obviously, there's a bit of a caveat there for some of our doctors working in remote areas where they are the only other doctor in the town. You're limited in who you can or can't see. But what I would say to that, and in our code, we've actually got, where physically possible, don't see someone that, is a close friend or colleague or family member, ideally, but, where obviously physically possible. My view on that too, though, is, we all travel from remote areas into the city to go to bigger centres for our shopping or do other things. And it's about planning ahead and having your own GP. I think it's really important for us to all have our own GP that can do preventative medicine. And I think when it comes to the self-care stuff, we're really keen on preventative self-care. And again, that's one of the key things that we've highlighted in our code is the personal responsibility, the ethical personal responsibility that healthcare workers have to be competent and to be at the best of their game when they're treating others. And that if you're impaired, that could be an ethical challenge, around non-maleficence, not doing harm. If we're impaired and we're trying to treat people, if we're too tired, if we're fatigued, if we're hungry or angry or running late, sometimes there's situations where we might not be treating people to an ethical standard, and that's something that we really wanted to call out.
Yeah, and it's quite hard to recognise that in yourself often, especially for overwork and that. And we've seen again, in the pandemic, that doctors sometimes going in without the proper PPE on and everything, thinking that they're doing the right thing. But, you know, if you take a long-term look at that, they're probably not helping the patient that they're seeing, and they're certainly not helping other patients because they suddenly have to come out of being able to treat anybody. So it's quite hard to be able to recognise it in certain circumstances, but yeah.
No, thank you again so much. And one of the things that I wanted to call out that's in our new code is our responsibility to treat each other with respect and dignity and professionalism. I think that's a really important principle as well, and that's in our code. But without further ado, I might move on to our second speaker, Dr. Hamish Meldrum. As I mentioned in the introduction, he's going to talk about ethics in the context of being a clinical GP, rural generalist, and also the owner and one of the immediate past DMS, so administrator of a large ethical corporate. So thank you, Hamish.
Thank you, John, and thanks, Lynn. That was great. Yeah, look, as John says, I was the DMS of Ochre for quite a while, probably effectively, you know, since we started in many ways with help from Ross Lamplugh, my co-founder. So a lot of the time I've been dealing with complaints and clinical issues and clinical governance, and I suppose that probably gives me some insights into how we can what we've learned and what approach we take. At the moment, I'm actually involved in talking to practices and talking to them about how we can, practices that might want to join Ochre, and one of the value propositions I put to practices is that we're an ethical corporate and we practice ethical medicine. I suppose that's sort of like, what does that mean? What does it? It's easy to say, but what does that mean? And one thing we do is that we have therapeutic guidelines, which are the consensus statements. We make those available to our doctors. We support the National Prescribing Service, which is which I think is, promotes the ethical and proper use and evidence-based use of medications. We, promote things like the HANDY guidelines, which are by the RACGP, which are non-pharmaceutical guidelines for managing conditions. We produce outcome reports where we can measure how our patients are doing, and we've actually produced outcome reports where we measure how Indigenous patients are doing versus non-Indigenous patients. Going back to Lynn's point, it's about there's often ethics is there's an element of social justice there, and we're interested in health inequality and reducing health inequality in our communities. So all those things are part of what we think are ethical. We like our doctors to be honest with patients. We don't want to undermine our colleagues. We always want to, don't be critical of your colleagues in front of patients. That can be very damaging. It can result in written complaints and lawsuits by, one brief sentence can be, can put somebody in years of court cases, and you might on reflection think that sentence wasn't well considered once you've got to know the full story. And consider the cost and benefits of what your clinical decisions. For example, we know that CT scans in the US probably, or imaging in general, probably causes 2% of cancers in the US, right? So are we being judicious in our use of CT scans and imaging? We know that if we use it for the right patients, the cost benefit is correct. If the risk is there, the benefit's there. But if the risk is really low, the benefit's not there, and the cost is still there. The cost to the community, the cost to the patient, and you're doing some harm potentially to the patient as well. De-prescribing versus prescribing. There's a bit of a bias to prescribing. We all think that prescribing more medications is more caring, but just probably challenge people to think, well, maybe de-prescribing can also be just as powerful and just as useful, especially for some of our elderly patients. So that's what we kind of mean. That's some of the philosophy that we take to practices when we talk about Ochre as an ethical corporate and practices ethical medicine. I want to talk about record keeping. We always get that's a bit of an issue with sometimes we get complaints about various GPs or nurses or whatever, that they're not keeping the right records. So, you know, the standard of record keeping is, you know, are you writing enough information that another clinician can come and pick up the care of that patient and understand what's going on? So you can write too much, you know, so, you know, you know, we've probably all encountered this from time to time, that somebody's written such a long essay, you know, you just really find it difficult to read it all and pick out the key points, right? So sometimes writing too much can be a problem, and obviously not writing anything really exposes you to a lot of risk, and exposes your patient to a lot of risk. And, you know, it's not, you know, we just do not call that ethical to not write, you know, reasonable records. You know, please update the allergies, please have an up-to-date problem list, please have up-to-date medication list. Again, lots of medications that are extraneous are also potentially problematic as well. Sharing patients. You know, we all pretty much all Ochre practices are group practices, right? Maybe Strawn is the exception with one doctor in Strawn, but pretty much we're all working together in group practices. And it's kind of interesting how doctors, we can be quite possessive over patients. Sometimes it's patients we don't want to see as well. But I know I get complaints sometimes of doctors, you know, they see a patient that they feel is their patient, and that may be correct. They may have seen this patient many times. They may feel like they have a good bond with this patient, and they actually, and the patient's booked in with another doctor, and they will actually, you know, take the doctor out of the appointment book and put it in their appointment book. They'll move them across. Like, you know, I'm their doctor, they should be seeing me. But, you know, the patient is, you know, you've got to respect the patient. The patient has the right to see the doctor of their choice. You know, they may be asking for a second opinion. They may have a gender specific problem, and they might want to see, you know, a different practitioner. And you know, my experience, and as John pointed out, I've been practicing for a while. You know, patients will drift away from you. That's okay. Let them drift away from you. They often come back to you as well. Like, you know, sometimes they come back in a week, a month, sometimes a year. But you know, it's kind of what happens, and you'll pick up other patients as well from other practitioners. It's not really a problem. Don't feel defensive. Don't feel worried that your patients don't like you just because they see another patient. Remember, one of the difficult ethical problems GPs get is ending a patient relationship. So we have some strategies around that. Please, you know, please call out to us if that's the case. Okay, please, you know, because we have some template letters. If there's a breakdown in trust between you and the patient, you know, we can talk you through how you might want to do that and explain to the patient that you no longer feel that you're in a therapeutic relationship with them, and they should seek a different practitioner. And but remember, you always have to provide emergency care. Okay, so even if you have ended the patient relationship and they were to come to the practice or to the hospital needing urgent care, you still have to provide urgent care to the patient. Working harmoniously. All our contracts at Ochre have this clause of working harmoniously. It's probably a little bit like a marriage. I mean, I think, you know, when you start, or a bit like a new relationship, you think, oh, of course we're going to work harmoniously. It's how easy is that? And probably everybody skips over that clause and think that's no big deal. Well, you know, well, how hard would it be to work harmoniously? And I don't think anybody gives it any second thought, right? But actually working harmoniously is actually not that easy. You actually have to put effort in. Just like anybody's been in a relationship for many years, you know that doesn't always come naturally. You've got to actually practice being kind. You've got to say hello to staff. You've got to treat staff well and with respect. I think Lynn covered off, but what I'd probably like to add to what Lynn says, that, you know, that requires some work, right? It doesn't always just happen that you're going to come to work and you're going to have a harmonious working environment. And it's not up to just the practice staff to do that. It's also up to the doctors and clinicians to come and make that effort as well. And remember, you know, people perceive doctors, rightly or wrongly, as perhaps being a bit of aloof, a bit arrogant, and maybe, maybe they're better educated than the staff and all the rest of it, and so it's up to the doctor to break down those barriers and show that, you know, they're just regular people as well, right? So, but the doctor has probably got to reach out and make the effort to demonstrate that. So I'd encourage people to think about that. Billing. Look, billing. My view on billing is that, you know, we have a requirement to be transparent to our patients. You go to a restaurant and, you know, maybe you get a surcharge at a restaurant, you know, you happen to go there on a public holiday and, you know, you didn't know about the surcharge, you get the bill and there's extra 10% on the bill. I don't know, I get annoyed. I'm sure other people get annoyed as well because I didn't know about the surcharge. And, you know, I've been to Bali and I've seen people, you know, argue over $5 on you know, or 5 cents, I meant to say, on a, you know, on a bus fare because, you know, they thought the fare was 5 cents and it's 10 cents and why aren't they charging me the local price? So people often, it's often about the injustice, right? So people aren't actually arguing over the money, they're arguing over the injustice of, you know, I thought it was going to be a certain amount and you're charging me a different amount. So I'd really encourage the doctors and to charge our billing policy, keep to the billing schedule, and it makes it easy for the receptionist to explain clearly what the out-of-pocket costs will be for patients, and then the patients know what it is and they accept it and they're happy. There's no surprises, right? So and we actually keep the same gap between a 23, a 36 and 44, just to make it easier for our receptionists to communicate that to patients. You know, mandatory reporting of doctors. You know, we have, you know, 280 doctors, and like we will get doctors come and say, I want to report this doctor. And, you know, probably no surprises, probably opiate prescribing would be the #1 reason. We'd have people contact us and say, I'm concerned about a particular doctor. And sometimes we investigate these things and there's really, you know, it will really be about one patient. And often we can manage it without any mandatory reporting. Often some people get in relationships with patients where they've actually, you know, become convinced that they are deserving of particular medications, and it's not a widespread, you know, malpractice and can be dealt with. But I probably would, but sometimes, you know, that things are more straightforward and, you know, maybe it does meet the threshold for mandatory reporting. But I would say if you're ever in that situation, you know, share your, you know, don't keep it to yourself, you know, talk to John, talk to myself, you know, bounce it off a colleague, a senior colleague, talk to your medical indemnity insurer. You might be surprised that, you know, it's the threshold may be a little bit higher than you realize. Often I find when I talk to the indemnity insurer, I say, look, this sounds, you know, this sounds like a bit of a concern. The indemnity insurer often tells me it actually doesn't meet the substantial harm criteria. So there's substantial harm criteria in mandatory reporting. So all as I'd say, the take home point is, you know, please use us. That's what we're here for. Okay. So please use us. Please talk it through. And look, doctors being sued. This is my last point. Look, it's always stressful, incredibly stressful to be sued. And I think every doctor perhaps would have it happen to them once in their career on average. So don't feel like you're a bad doctor if you get sued, because you're actually just an average doctor if you get sued once. There's 2 types of of litigation. You know, you could divide them to 2 types. It's successful, where they actually successfully litigate, and there's unsuccessful, where it gets defended. So if you look at successfully defended lawsuits, it's often about communication. The patient is often upset about the communication, and they're angry about the communication. They feel they've been spoken down to. They feel they haven't been listened to. They feel disrespected, and then they want to litigate. And often that's not always successful, but it's very stressful for everyone involved. And then there's the successful litigation. That's often about delayed or misdiagnosis. And think about that, because what Avant has shown, and they wrote a really good report on this a couple of years ago, is that, you know, it's not about ordering lots and lots of tests. And, you know, one of the key thing in the Avant, you know, analysis was that, you know, clinical examination, you know, examine your patients, you know. So sometimes it's not that the doctor hasn't ordered a fancy test. It's the fact that the doctor hasn't done just a regular, normal, sometimes perhaps a little bit thorough examination of a patient, right? So examination skills are still relevant in 2020. And I think that's probably my 10 minutes, John. So I'll leave it there.
Thanks so much, Hamish. Really important and pertinent points for our doctors in practice, obviously drawing on your wealth of experience there. So thank you so much for that. I really liked how you highlighted sort of choosing wisely concept of making sure that we're judicious with our test ordering. And I think, you know, again, we've underpinned it in the Ochre Code that we have a responsibility to the law. We have a responsibility to abide by the law, and that also goes to spending the taxpayer dollars judiciously, like we have a responsibility for that. So that cuts across ordering tests appropriately, but also it's good medicine, as you've pointed out, that many of these ethical principles will actually drive the good practice of medicine around appropriate examination, around appropriate ordering of tests. And one of the things I've loved about being a rural generalist, a rural GP, is often we've had to lean more on our physical examination skills. We don't always have access to fancy tests. And I actually think it's more interesting medicine. You actually feel like you're contributing and that you're bringing more skill to the interaction as well. So I think there's something to be said for a lot of those principles that you've outlined. Before I go on to Miranda, I just do want to highlight to people that there is a question and answer facility on the webinar. You can go to the Q&A tab in the bottom of your screen and you can ask questions in real time. We'll monitor those. We'll have some time at the end for questions. I would certainly commend that to you to ask some questions of our panelists while we've got the benefit of such a high caliber panel. So I'll move now on to Miranda. Thank you, Miranda, for coming. We've really appreciated your input and contribution through the COVID mindfulness series that you did for us. And many of our colleagues became very stressed, and the COVID environment has really placed a lot of doctors under stress and affected them and many other staff as well. So welcome, and we look forward to hearing your piece on our responsibility around wellness and self-care.
Oh, thank you. Thanks, John. And I'd like to focus in my section on how we practically put in place and adhere to the self-care requirements of the ethical codes. So if we have a look at the Declaration of Geneva that states, I will attend to my own health, well-being and abilities in order to provide care of the highest standard. So psychologically, we know that when we are really tired, which we all get, stressed, distracted by problem solving or worrying or coping with lots of things at once, which happens to all of us at various times, then we actually might not be being our best selves and therefore able to provide care of the highest standard. So it doesn't just mean when we have a diagnosed health or mental health condition. So I think we can probably all relate to times when our stress response is activated. It might just be because we know we've got people in the waiting room or we've got a lot going on or we're just adapting to all the changes that are occurring. And so when that happens, it's just actually biology, which results in us not listening so well to people. We can get decision fatigue. We can rely on sort of automatic pilot behaviours, those well-grained things, which are often really useful and really handy in emergencies, but maybe not so much at other times. We can find that we're just not present with our environment, our context, the people around us. Sometimes for some of us, we can take our stress out on others. Our automatic defences that we all have to protect ourselves when we're stressed can kick in. We might not communicate as well as when our stress response isn't activated. And we do definitely know that when our stress response is activated, even at the level where we may not even particularly feel stressed, but it's just that low level chronic stuff that we can get a little bit used to, that it impacts on our capacity to be self-aware. And so then if we're not self-aware, we aren't really paying attention to when we're triggered by what's going on around us or by people, and therefore react according to that. And we're also not always so in tune with when our unconscious biases are activated as well, which can impact on our decision making. We might also not resolve conflict well, find it tricky to make difficult decisions under pressure, communicate bad news well, or not collaborate. So, you know, as I mentioned, they're all behaviours really typical of stress in some form. Might even just be tiredness or overwork or adjusting to changes. It doesn't mean we need to stop working or should be reported to the medical board, of course, but it just points to the fact that we need to attend to our well-being because it's a dynamic process, and that it can be a bit of a slippery slope to it starting to sort of go downhill and end up causing us bigger problems. If we have a look at the medical board's code of conduct, you actually can't follow that without a high degree of self-awareness or insight. And Ochre's new medical code of conduct, number 3.4 even, requires staff to maintain acceptable standards of behaviour towards others. So maintain acceptable standards of behaviour towards others. And if we think about that, that actually requires self-awareness, because we need to be able to moderate our behaviour towards others. And, you know, even all the philosophers over time have really emphasised that the key to a good life, to a functional community, to well-being is self-awareness. Socrates even went so far as to say that the unexamined life is not worth living. And no one else can do this for us. No one else knows what's going on in our lives at any one moment, any one point in time. They don't know the context, and they don't have privy to all of the information, and they can't be the one that decides on the wisest action. So it really is that concept around self-responsibility that's so important. But self-awareness of struggle or stress without the capacity to self-regulate that is torturous even at times. So we definitely need that other skill to go hand in hand with that self-awareness in order to be ethical in our lives. We need to be able to calm ourselves. We need to be able to unhook from unhelpful thinking when it arises, when we're aware enough to know that it's there. We need to know how we can shift perspective of things, to tolerate our own patterns and behaviours and those of others. So that combination of self-awareness and non-reactivity, or the capacity to self-regulate, is just crucial. And many branches of science talk about how it is those two things hand in hand that are the key to personal success in life. So this is self-care at its most basic level, actually. And the whole concept around self-care, which was actually prevalent in sort of ancient Greek time, came into our more modern vernacular in the 1980s, when Aubrey Lord started writing and talking about, she was a Black American activist, and she started talking about the greater the pressures that are on us, then the greater the need is for self-care. And we can probably all relate to, actually, that's the time when we don't take care of ourselves. We're just trying to get through stuff. But that's also the time when we can be less self-aware and more likely to be doing stuff that can be unpleasant, if not harmful to others and ourselves. So the greater the pressures, whatever they might be for us, the greater the need for self-care. And practically, that means being as self-aware as possible and being able to self-regulate. So I reckon that there's a bit of a triad of self-care strategies that really need attending if we're talking about how we can be ethical and aware in this sort of space. And one is the stuff that we all know about. You know, one of those three components is the lifestyle stuff that clinicians get trained in as being really important. They underpin health and mental health, the exercise, the nutrition, the capacity to sleep well, to use our brain, and to keep social contact. And also, we know, because these are the things that actually different branches of science say are really important, is that capacity to have some meaning in our life, or to have some sort of spiritual connection as well. A good way to remember those is actually, if you think about seeds, but you have to put an extra S on the end as well. Because then they can stand for sleep, exercise, education, or using our brain, diet or nutrition, social contact, and then an extra one for spiritual or meaning in our life. So they're the things that we know can really help us to keep some balance and to look after ourselves. One of the other three is about our interactions that we have, particularly between our home life and within our workspace, because we need to negotiate workloads at times. We need to resolve conflict. We need to be able to communicate well. We need to collaborate and to be part of a team most of us, in most of our workplaces. And workplaces have a responsibility to contribute towards our self-care, most definitely. But there's that interface with us that we can be responsible for, and that's how we do that. We do that by having good negotiation skills, conflict resolution, teamwork, communication skills. And, you know, we all have strengths and weaknesses in different areas of our lives. And for some of us, that attending to our self-care means attending to those. And then the third one is what I've actually really talked about so far is what we call intrapsychic. So our internal capacities to attend to the doings of our mind and the doings of our body. So attending to stress as it arises physiologically for us, when the beating of our heart and the muscle tension means that we are struggling to really be present in the room. And also our mind, it means attending to how our mind works, knowing how we tend to think and react to different things and the grooves that we get into that have developed over time and how we respond to particular people, and to really know that well, so that then we can actually take care of stuff that needs taking care of, that we can calm ourselves, settle ourselves in the moment of pressure, so that we know when our unhelpful thinking pattern or the ways that we have jumped to conclusions or whatever it might be is actually influencing how we are interacting with somebody, how we're making decisions that therefore lead on to our behaviour. And of course, there's many options, and we actually have to find our own way. We have to know ourselves well enough to be able to attend to what needs to, and then we have to find our own way to work on that stuff in the way that works for ourselves. And in different times in our lives, different things are required and different ways are helpful for our self-care. One of the excellent things that I think has come out of this year has been the increased access to services online, so more programs that are available for people to work through in terms of looking after themselves, and there's some amazing, great resources and programs out there. But also just that capacity now for particularly rural clinicians to be able to access the telehealth services, so that for people in small towns you don't need to contact your local service providers for that. It's just so much easier. Because we know that it can be hard enough to reach out and get somebody to take care of to help us to take care of ourselves. So there's lots and lots of options. Ultimately, we do have to find our own way. And I know that Ochre are really committed to helping people to link in with services. There's EAP services and, lots of other resources that they have available. And so I guess just to finish on that note, that it's important not only for our ethical work practices as we're here talking about today, but actually our self-care is just important to have a good life, hey? So I'll leave you with that one, and yeah, thanks. Happy to answer any questions.
Wow, Miranda, that was fantastic. Thank you so much. Look, I think one of the key things that you struck on was about self-awareness. And I think that insight is really important, and the fact that we've got to work on that for our relationships, but also medically and clinically, we need to have insight into how we're performing, what our level of skill is, what we know and what we don't know, trying to get away from any unconscious incompetence. So that was great. Thank you so much. And thank you for highlighting our EAP. Ochre has a strong focus on wellness. We're starting a wellness committee next year. So we're really going to place a strong emphasis on wellness of our whole Ochre community, our family. And I strongly commend to people having their own GP and psychologist. I personally see a psychologist, and that's out of prevention. Like, I think this has been a really stressful year for all of us. And I think it's important to think about being preventative in this space, not just waiting for the wheels to fall off and waiting for the pathology. So thank you so much for underlying that. Now, we do have quite a few questions. One of the best questions that I've seen there is, it's for you, or it's not really for you, Miranda, it's more of a statement. It says, Miranda is a rock star. And I actually think, many of us would agree with that. But there is a couple of questions, and I do want to go to Lynn for a question. And there's a question there saying, how do you think ethics will change over the coming years in general practice as things evolve?
Yeah, thanks. guess at one level, not a great deal. I mean, if you saw what I was discussing, if you go back centuries, it still hasn't, the basics of it has stayed the same. I think what is changing the most is around that patients having more say in that respect for patient autonomy and everything. So maybe that will change, and a bit more maybe within Australia, kind of acknowledging that actually to go against that, but patients don't always want that. And in respecting different cultures, that sometimes it's the family that has more say and things like that. So a bit more acknowledgement that there are differences, and respecting someone's autonomy can take a whole lot of different, can look very different for different people. And sometimes it's the right not to know something. Sometimes it's actually the right for other people to make those decisions. And I mean, your basic medical ethics, that idea of beneficence, non-maleficence isn't going to change. Probably the idea of justice and the equity and how we treat people, understanding a little bit more about the social determinants of health and how we can distribute things better, and how we can help our underserved populations more. It's probably the area I think maybe that will get more attention.
And we've certainly been through a time of fairly tumultuous change with ethics in terms of the government or, community's approach to things like euthanasia, to abortion, to same-sex relationships. Just in the last 15 years in Australia, as ethics evolves, and we know that ethics is really the prevailing community values of a time, and that's what defines ethics as we evolve. But thank you for that. There's another question here. Well, it's a bit of a statement, but I think it would be good for Hamish to approach this one. But it's saying, Hamish, you mentioned that we don't own our patients. We've got Antoinette from Casey who's asking, essentially putting to us, what about continuity of care in that context? How important do we balance off continuity of care versus...
I completely agree with Antoinette that continuity of care is really important. It's an interesting one though, isn't it? I think general practice has changed over the last 20 or 30 years. I think what I've noticed is there's a lot more part-time GPs, and there's a lot more, turnover of GPs perhaps than there was, 20, 30 years ago. So I suppose what, we're moving towards a little bit is that, patients are actually loyal to a practice rather than loyal to an individual doctor. And I think that's, it's evolving and it's changing, and different patients would feel differently about that. I know in Sydney, it's probably the same in Casey and Canberra, or might not be, I don't know, but often patients will have their doctor that they go to when they're sick and they want to get sorted out. And sometimes they have another practice or doctor they'll go to when they just want a script or a work certificate or something like that. I mean, at Ochre, we're trying to be the practice that you go to when you're sick, rather than just the practice you go to for a work certificate. That's not the type of medicine we want to do. But so I suppose we've got to be a little bit flexible about what that means, that continuity of care. I think it's great if a practice can capture a patient, and I just probably would say that we can't always be everything to a patient, and that sometimes a patient is going to want to come in on a Thursday and we don't work on a Thursday, or they're going to want a second opinion, or they're going to want to see if they're my patient, there'll be times where they want to see a female doctor, right? And that's okay.
Thanks, Hamish. There's just another comment that's come through on this, saying that continuity is important, but sometimes a second set of eyes reveals things that you might not have seen. I've certainly heard of this in our locum space. So at Ochre, we manage many rural and remote sites where we do supply backup workforce and relief workforce with locums. And certainly I've heard of anecdotes where a locum's come in and just with a fresh set of eyes has actually picked up something fairly important or serious or helped the doctor. And a lot of the doctors are quite happy with that. They're actually appreciative of another set of eyes. And I think it can be really helpful. So that's a really, I think that's a really useful addition.
I think I told you the story recently, John, where I was in Burke and one of our locums, actually Miranda will know them, Andrea Hedgelands, that rang me up and said, "Oh, gee, that patient with tertiary syphilis, gee, they're really, that's really impacting their life." And I said, "What?" I mean, this patient had been going to all the doctors in Burke, and it was actually a locum that picked up the tertiary syphilis. So, there you go.
No, I think that's a great point. There is another interesting question here, and I think probably for Lynn. How do you manage or approach doctors' own cultural or religious beliefs when they're working in general practice?
That's a really good question. And I mean, I can give a medical ethics point of view on it, and the practical point of view might be quite different. It's actually, I do a introductory bioethics course for FG students. And one of their exam questions is based on a quote from Julian Savulescu saying, basically, if a doctor's not willing to practice and do everything that's legal, then they shouldn't be a doctor. And you'll get half of the students who support this and go, yes, you know, if it's a legal thing, you shouldn't be bringing in your own personal beliefs, cultural, religious beliefs, and stopping people from getting access to certain procedures or whatever. And then half will say, well, no, you've got your own rights as a doctor as well. Certainly, you know, I guess I say to them, you can choose your specialty. And by doing that, you're going to choose what you do or what you don't do. And maybe you can choose your location. So as a potential patient, I would be very worried if I lived in a more rural area or remote area and none of the doctors there, if they all had the same kind of those same beliefs that weren't willing to offer something, then I would find that a bit of a problem. But I think, you know, in most cases, you know, you have to be able to make those choices as a doctor, because you have to be able to live with how you do your work and what you offer patients and everything. Otherwise you're under moral distress if you're being forced to go against what your own beliefs are. And I think in most circumstances, you can have both. You can practice most of medicine and there may be a small amount that you don't, but you don't stop that from, you know, you have to be able to pass on to someone else. You have to be upfront with your patients and say, oh, this, I won't do this, but these are people that I can refer you to. This, so we have this around, you know, offering abortions and things like that. We have these rules with the euthanasia rules that are in Victoria and, you know, fairly likely to come into Queensland. I think Western Australia have got them coming in. It's slightly different in that you don't have to refer them on to someone else. You can just say, well, no, that's not something that I would support, and there's no need to refer them on to someone else.
Thank you so much, Lynn. That just about wraps us up for this evening. I'd like to extend a massive thank you to our panelists for giving up their time and preparing for this evening, and for what was, I think, a very stimulating and thoughtful discussion. So thank you to all of you for attending and for talking with us this evening. I'd like to extend a huge thank you and to all of the participants. Thank you for coming along and participating as well. We're looking forward to more of our Ochre Academy events as we go forward. Feel free to send any further questions to myself or to Caroline at Ochre. And there's some contact details there for you. Yeah, just thank you again so much for all attending. We'll make sure that you pass this on to your friends in the practices. There will be a recording available on the website. And yeah, just thank you all again for attending, and we'll look forward to seeing you next time. Goodbye.
Thank you, John. Thanks, Lynn. Thanks, Miranda.